Welcome to today's session. I'm Jemisha, working as assistant professor at Emmanuel Arthur College of Pharmacy. Today we are going to learn about asthma. Asthma is a chronic inflammatory disorder of the airways. The word chronic means that the disease persists for a long period and usually requires lifelong management. In asthma, the airways become inflamed and highly sensitive to various stimuli called triggers. When an asthma patient is exposed to these triggers, the smooth muscles surrounding the bronchi contract, the airway lining becomes swollen, and excess mucus is produced. These three changes narrow the airways and reduce the flow of air into and out of the lungs. The common symptoms of asthma are wheezing, shortness of breath, chest tightness, and cough. These symptoms may come and go and are usually worse at night or early in the morning. One important feature of asthma is that the airflow limitation is usually reversible either naturally or after treatment with medications. Next, epidemiology. Asthma is one of the most common chronic respiratory diseases worldwide. It affects more than 300 million people globally, and its prevalence is increasing every year. Asthma can occur at any age, but it commonly starts during childhood. It affects both males and females, although boys are more commonly affected during childhood and females during adulthood. The increasing prevalence of asthma is associated with urbanization, industrialization, air pollution, smoking, and increased exposure to allergens. Asthma is also one of the leading causes of emergency hospital visits and from school and work. Therefore, it creates a significant social and economic burden. Next, etiology. The exact cause of asthma is not fully understood. It usually develops due to a combination of genetic and environmental factors. Genetic factors include a family history of asthma, allergic rhinitis, or eczema. A person with allergic disease is more likely to develop asthma. Environmental factors include exposure to house dust mites, pollen, mold spores, pet dander, cigarette smoke, air pollution, and occupational chemicals. Viral respiratory infections during childhood may also increase the risk. In many patients, these factors work together to produce chronic airway inflammation and repeated asthma attacks. Risk factors. Risk factors are factors that increase the possibility of developing asthma. Host factors include genetic predisposition, atopy, obesity, and family history. Atopy refers to a tendency to develop allergic conditions. Environmental risk factors include active smoking, passive smoking, indoor and outdoor air pollution, occupational exposure to dust and chemicals, and respiratory infections. Obesity is also considered a risk factor because excess body weight can affect lung function and increase inflammation. Identifying these risk factors is important because controlling them may help reduce asthma symptoms. Next, common asthma triggers. Asthma triggers are substances or conditions that can provoke an asthma attack. Every patient may have different triggers. Common triggers include house dust, pollen grains, animal fur, mold, mold spores, cigarette smoke, air pollution, cold air, exercise, emotional stress, and respiratory infections. Certain medications such as aspirin, NSAIDs, and beta blockers can also trigger asthma in some patients. Strong perfumes and chemical fumes may also worsen symptoms. Avoiding these triggers is an important part of asthma management because it reduces the frequency of attacks and improves quality of life. Next, pathophysiology. The pathophysiology of asthma mainly involves chronic inflammation of the airways. When a trigger enters the airway, immune cells such as mast cells, eosinophils, and T lymphocytes become activated. These cells release inflammatory chemicals that produce swelling of the airway lining. At the same time, the smooth muscles around the bronchi contract, causing bronchoconstriction, and the mucous glands produce thick mucus. These changes narrow the airway and make breathing difficult. Repeated inflammation over many years can lead to permanent structural changes in the airway if asthma is not properly controlled. Next, mechanism of asthma. The mechanism of asthma begins with exposure to an allergen or trigger. The allergen activates mast cells, which release mediators such as histamine, leukotrienes, and prostaglandins. These substances produce bronchoconstriction, airway edema, and mucus hypersecretion. As the airway becomes narrow, airflow decreases and the patient experiences wheezing, cough, chest tightness, and breathlessness. This inflammatory response may be immediate or delayed, which is why some patients continue to have symptoms for several hours after exposure to the trigger. Next, airway remodeling. If asthma remains uncontrolled for a long time, chronic inflammation can permanently alter the airway structure. This process is known as airway remodeling. It includes thickening of the basement membrane, enlargement of airway smooth muscles, increased mucus producing glands, and fibrosis. These structural changes make the airways less flexible and reduce the reversibility of airflow obstruction. As a result, patients may develop persistent breathing difficulty. This is one of the reasons why early diagnosis and regular use of controller medications, especially inhaled corticosteroids, are very important in asthma management. Next, clinical manifestations. The clinical manifestations of asthma vary from one patient to another. The four classical symptoms are wheezing, shortness of breath, chest tightness, and cough. Wheezing is a whistling sound produced due to narrowing of the airways. Shortness of breath occurs because the lungs are unable to move enough air. Chest tightness is often described by patients as a feeling of pressure or heaviness in the chest. Cough may be dry or associated with small amount of sputum and is often worse at night or early in the morning. Some patients may only have cough, which is known as cough variant asthma. The symptoms usually occur in episodes and may be triggered by exercise, cold air, allergens, respiratory infections, or emotional stress. Between attacks, some patients may remain completely symptom free. Signs of severe asthma attack. A severe asthma attack, also called an acute exacerbation, is a medical emergency that requires immediate treatment. During a severe attack, the patient may experience extreme shortness of breath, rapid breathing, severe wheezing, and difficulty in speaking full sentences. The patient may also use accessory muscles of respiration, such as the neck and shoulder muscles, to help with breathing. Other warning signs include increased heart rate, bluish discoloration of the lips or fingers called cyanosis, and decreased oxygen saturation. In very severe cases, there may be a silent chest, which almost no air movement is heard. This indicates critical airway obstruction. Without prompt treatment, a severe attack may lead to respiratory failure and can be life threatening. Next, classification of asthma. Asthma can be classified according to its severity and the level of symptom control. Based on severity, asthma is divided into intermittent, mild persistent, moderate persistent, and severe persistent asthma. Intermittent asthma causes symptoms less than 2 days a week. Mild persistent asthma causes symptoms more frequently, but daily activities are usually not affected. Moderate and severe persistent asthma produce frequent symptoms, nighttime awakenings, and limitations in normal activities. Classifying asthma helps healthcare professionals select the most appropriate treatment and monitor the patient's response. Complications. If asthma is not properly controlled, it can lead to several serious complications. One of the most dangerous complications is status asthmaticus, which is a severe asthma attack that does not respond to standard treatment and requires emergency medical care. Other complications include respiratory failure, recurrent respiratory infections, pneumothorax, and airway remodeling. Patients may also experience sleep disturbances, reduced physical activity, anxiety, and poor quality of life. Long term uncontrolled asthma may result in repeated hospital admissions and increased healthcare costs. Next, diagnosis. The diagnosis of asthma is based on a combination of medical history, physical examination, and lung function test. The physician will ask about symptoms such as wheezing, cough, breathlessness, and chest tightness. A history of symptoms that worsen at night or after exposure to allergens strongly suggests asthma. During physical examination, wheezing may be heard on auscultation. However, some patients may have a normal examination between attacks. Because symptoms alone are not enough, objective tests are required to confirm the diagnosis. Okay, spirometry. Spirometry is considered the gold standard investigation for diagnosing asthma. It measures the amount of air a patient can inhale and exhale and how quickly the air can be expelled from the lungs. Two important values are FEV1, which is the forced expiratory volume in 1 second, and FVC, which is the forced vital capacity. In asthma, airflow obstruction is usually reversible after giving a bronchodilator. An increase in FEV1 of at least 12% and 200 milliliters supports the diagnosis. Spirometry is also useful for assessing disease severity and monitoring the patient's response to treatment. Next, peak expiratory flow rate test. Peak expiratory flow rate or PEFR measures the maximum speed at which a person can exhale. It is simple, inexpensive, and portable method for monitoring asthma. Patients can use a peak flow meter at home to check their lung function regularly. A reduction in PEFR may indicate worsening of asthma even before symptoms become severe. Therefore, many asthma action plans include daily peak flow monitoring. Regular monitoring helps patients to recognize early signs of an attack and seek treatment before the condition becomes serious. Other diagnostic tests, in addition to spirometry, several other investigations may be useful. Chest X-ray is mainly performed to rule out other lung diseases because it is often normal in asthma. Blood tests may show increased eosinophil count or elevated serum IgE levels, especially in allergic asthma. Fractional exhaled nitric oxide or FeNO is a marker of airway inflammation and may help in diagnosis. Allergy skin tests can identify specific allergens responsible for triggering symptoms. Arterial blood gas analysis may be performed in severe asthma attacks to assess oxygen and carbon dioxide levels. Together, these investigations help confirm the diagnosis and guide treatment. Next, treatment. Goals of treatment. The main aim of asthma treatment is to achieve and maintain good symptom control while reducing the risk of future exacerbations. The first goal is to relieve symptoms such as wheezing, cough, chest tightness, and shortness of breath. The second goal is to prevent acute asthma attacks that may require hospitalization. Treatment also aims to maintain normal lung function and allow patients to perform their daily activities, including work, school, and exercise, without limitations. Another important goal is to minimize the adverse effects of medications by using the lowest effective dose. With proper management, most asthma patients can lead a normal and active life. Next, non-pharmacological management. Non-pharmacological management is an essential part of asthma care and should be combined with medications. The first step is to identify and avoid triggers such as dust, pollen, cigarette smoke, pet dander, and strong chemical odors. Smoking cessation is strongly recommended because smoking worsens airway inflammation and reduces the effectiveness of treatment. Patients should maintain a healthy body weight and perform regular physical activity according to their tolerance. Annual influenza vaccination and other recommended vaccines can reduce respiratory infections that may trigger asthma attacks. A clean home environment, proper ventilation, and reducing exposure to allergens also improve asthma control. Next, patient education. Patient education is one of the most important aspects of asthma management. Patients should understand that asthma is a chronic disease and that regular treatment is necessary even when they are feeling well. They should be taught the correct inhaler technique because improper use can reduce the effectiveness of medications. Patients should also know how to identify the personal triggers and avoid them whenever possible. An asthma action plan should be provided so that patients know what to do if symptoms worsen. Education also improves medication adherence and reduces hospital admissions. Next, pharmacological management. The medications used in asthma are broadly divided into two groups: reliever medications and controller medications. Reliever medications provide quick relief by relaxing the airway muscles during an asthma attack. Controller medications reduce airway inflammation and prevent future attacks. The treatment plan depends on the severity of asthma and follows a stepwise approach. If symptoms are not controlled, treatment is stepped up. Once good control is achieved, therapy may be stepped down under medical supervision. The main aim of pharmacological treatment is to control symptoms and improve the patient's quality of life. Next, inhaled corticosteroids. Inhaled corticosteroids, commonly called ICS, are considered the cornerstone of long-term asthma management. Examples include budesonide, beclomethasone, and fluticasone. These drugs reduce airway inflammation, decrease mucus production, and reduce bronchial hyperresponsiveness. Regular use of inhaled corticosteroids decreases the frequency and severity of asthma attacks and improves lung function. Common side effects include oral candidiasis, sore throat, and hoarseness of voice. These side effects can be minimized by using a spacer device and rinsing the mouth after inhalation. Because of their effectiveness, inhaled corticosteroids are recommended as first-line controller therapy in most asthma patients. Next, short-acting beta-2 agonists. Short-acting beta-2 agonists are the most commonly used rescue medications for asthma. The main example is salbutamol, also known as albuterol. These drugs stimulate beta-2 receptors in the bronchial smooth muscle, leading to rapid bronchodilation. They usually begin to act within a few minutes and provide quick relief from wheezing and breathlessness. Common adverse effects include tremor, palpitations, tachycardia, and nervousness. Although they are highly effective for symptom relief, frequent use may indicate poor asthma control. Therefore, patients who need short-acting beta-2 agonists very often should be reassessed and may require stronger controller therapy. Next, long-acting beta-2 agonist. Long-acting beta-2 agonists provide bronchodilation for about 12 hours or longer. Common examples include salmeterol and formoterol. They help control symptoms during the day and night and reduce the frequency of asthma attacks. However, long-acting beta-2 agonists should never be used alone in asthma because they do not treat airway inflammation. When used without inhaled corticosteroids, they may increase the risk of severe asthma exacerbations. For this reason, they are usually prescribed in combination with inhaled corticosteroids. Fixed dose combinations improve patient compliance and provide better asthma control. Next, leukotriene receptor antagonist. Leukotrienes are inflammatory chemicals that contribute to bronchoconstriction, mucus secretion, and airway inflammation. Leukotriene receptor antagonists block the action of these chemicals and help reduce asthma symptoms. The most commonly used drug in this class is montelukast. It is taken orally and is particularly useful in patients with allergic asthma and exercise-induced asthma. Montelukast is generally well tolerated, but some patients may experience headache, abdominal discomfort, or neuropsychiatric effects such as mood changes. Although these drugs are not as effective as inhaled corticosteroids, they are useful as an additional treatment option in selected patients. Next, anticholinergic agents. Anticholinergic drugs are another group of bronchodilators used in asthma management. The most commonly used drug is tiotropium, and in acute attacks, ipratropium bromide may also be used. These drugs work by blocking muscarinic receptors in the airways. As a result, the bronchial smooth muscles relax, leading to bronchodilation and improved airflow. Anticholinergic agents are usually not the first choice for routine asthma treatment. They are mainly used as add-on therapy in patients whose symptoms whose symptoms are not adequately controlled with inhaled corticosteroids and long-acting beta-2 agonists. Common side effects include dry mouth, throat irritation, constipation, and occasionally blurred vision. Overall, these drugs are well tolerated and can improve lung function when used appropriately. Methylxanthines. Methylxanthines are one of the older class of drugs used in asthma. Theophylline is the most commonly used drug in this group. Theophylline works mainly by inhibiting the phosphodiesterase enzyme, which increases cyclic AMP levels and causes relaxation of bronchial smooth muscles. It also has mild anti-inflammatory effects. Although theophylline can improve breathing, it is not commonly used today because it has a narrow therapeutic index. This means that the difference between the effective dose and the toxic dose is very small. Common side effects include nausea, vomiting, headache, insomnia, palpitations, and tremors, and high blood levels. It may cause serious complications such as arrhythmias and seizures. Therefore, therapeutic drug monitoring is often required. Next, biological agents. Biological agents are newer drugs used in patients with severe asthma that remains uncontrolled despite standard treatment. These medicines target specific inflammatory pathways involved in asthma. For example, omalizumab acts against IgE antibodies, while meplozumab and benralizumab target interleukin 5 pathways. Biological therapy can reduce the number of severe asthma attacks, decrease the need for oral corticosteroids, and improve the quality of life of patients with severe allergic or eosinophilic asthma. These drugs are usually given by subcutaneous injection and are reserved for selected patients because they are expensive and require specialized supervision. Management of acute asthma exacerbation. Acute asthma exacerbation is a sudden worsening of asthma symptoms and requires immediate treatment. The first step is to assess the severity of the attack and provide oxygen therapy if oxygen saturation is low. Rapid acting bronchodilators such as nebulized salbutamol are given to relieve bronchoconstriction. Ipratropium bromide may be added in moderate to severe attacks. Systemic corticosteroids such as prednisolone or hydrocortisone are administered to reduce airway inflammation. In severe cases, intravenous magnesium sulfate may be used because it helps relax bronchial smooth muscles. If the patient develops respiratory failure, intensive care management and mechanical ventilation may be necessary. Early treatment of acute exacerbations can significantly reduce complications and mortality. Thank you.